Hi everyone, my name's Wendy Trevathan and welcome to my podcast called Your Nurse Voice Matters. And today I'm delighted to have with me Toni Hoffman from Bundaberg. Hi Toni.
Hello.
Nice to have you with us today. Now, Toni Hoffman, some of you may know Toni, some may not. I definitely knew Toni's name when she became involved with the Bundaberg Dr. Patel issues, I'll say, back in the early 2000s. But I'm here, Toni's here today to talk through with an angle around client advocacy and how important that is for our nurses to really keep the community safety in the utmost of their mind, no matter who you need to speak to around that. And Toni's certainly an expert in this area. So, Toni, welcome to the podcast. It's great to have you here. But we might start with going back in time with, your credentials and where you started nursing and what qualifications you have.
So I started back almost with Florence Nightingale, I feel, um, back at the Princess Alexandra in Brisbane and went went to the UK to do midwifery, and I did an ICU course when I was in London. So I worked in the UK for about 3 years and came back to Australia and then went and worked in eventually I did a bit of rural and remote and worked in Tasmania, and then went over to Saudi Arabia for 6.5 years in total to two different places. To Riyadh, I was there during the Gulf War, working in ICU, and I went back to Jeddah, I think it was in about um, 98, and was there for another 14 months. Then came back to Australia and I was doing my master's in bioethics, and wanted somewhere to go that I thought would be quiet enough to allow me to do that and work at the same time. And the job in Bundaberg came up, and I thought, well, that sounds good. And I thought that'll be a nice, quiet job, just a small ICU, 5 beds. I was used to sorry, you're going to hear my cat. And there's nothing that I can do about it. He's 23 years old and
No.
he's deaf and he can smell chicken cooking. And anyhow, um, so ignore him. Um, so so I was doing my master's in bioethics and came to Bundaberg to take job as a manager in the ICU, and did a grad cert in management at the same time. So at one point I was doing my master's, a grad cert in management and working full time. So I was
Wow.
pretty busy. And then I started here in 2000, and then in 2003 Dr. Patel started here in Bundaberg, and yeah, things changed after that.
Mm. And
Yeah.
I just mentioned before we started, like there is a podcast around this whole scenario with Dr. Patel, and I've got up to at the moment episode 4 talking about that, and he actually explored your experience and credentials from overseas and highly regarded and experienced. So I kind of think you've downplayed that a little bit, but you've had a vast experience in managing wards and in the clinical experience in a lot of contexts around the world before you came to Bundaberg. So, a wealth of experience and knowledge. So, so the Dr. Patel evolution, shall I call it? We might spend a few issues just talking about that, but I want to focus more on today what you're doing now and what nurses can do now for client safety issues if they're concerned. So let's just spend a couple of minutes sort of summarizing what happened because people can read about it, they can Google it, and also go to this podcast called Sick to Death to find out the background and the in-depth story around that scenario. So can you just give us a summary of what happened in those early years and
Yeah, well,
and your struggle to bring that to everyone's attention?
yeah. It what happened over a 2-year period, and we only became aware of what happened here really after it was all over. We were very aware that, when I say we, I mean the nurses in ICU and some of the doctors were very aware that there were big clinical competence issues with Dr. Patel, just by the amount of patients that we were getting back from the surgical intervention into the ICU. And there were quite a few red flags. He'd been recruited from the States on an area of need visa, to work as a surgeon in Bundaberg, not as a director of surgery. But within 2 weeks, he was promoted to the director of surgery here in Bundaberg. And the problems started pretty much right from the beginning. I made a formal complaint after 6 weeks of him being here, when he described a patient that came back brain dead from theatre as being stable. And he was stable because he was on 100% oxygen and a maximum inotropes, but he was far from stable in the big scheme of things. And him and I had a bit of a altercation because he was very cross with the nurses, that the nurses had told the patient's family that the patient was very unstable, whilst he was telling the family that the patient was stable. So that was probably the first issue. And this patient was an esophagectomy, which of course should never have been done in a small hospital like Bundaberg, that didn't have the follow-up ability there to provide follow-up care for this type of surgery. And this patient went on to pass away, I think 5 days after he was admitted to the ICU. And he actually became the first patient that was a manslaughter, one of the manslaughter charges at the end. And so we kept seeing a lot of complications, a lot of very strange things happening, a lot of wound dehiscence. These were the things that were highlighted to me as things that weren't normal for what was going on in the hospital.
So I might just interject there to explain for those that are not nursing or not medically orientated. A wound dehiscence is where you have a complete breakdown of the wound through all the multiple levels, and you also have internal organs, mainly the bowel, coming out of the abdominal cavity. Just for those that don't understand that concept.
Yeah, and it's quite rare over
Mm.
my career. It's quite rare to see a wound dehiscence. You do see them, but it isn't common.
I,
But
I remember seeing one in my second year on a surgical ward, and oh my goodness, it's frightening, absolutely
mm,
frightening when it happens.
yeah, these were all to different degrees. They weren't all complete wound dehiscence.
Hmm.
Some were partial, but at any given time, we might have 2 or 3 in ICU at any given time that were Dr. Patel's patients. And to highlight how dysfunctional the hospital was, we spent 6 months, I think, at meetings arguing the definition of wound dehiscence. At that same time, Dr. Patel was stopping all of the checks and balances that were in place within the hospital. He was running his own morbidity and mortality meetings. He had stopped the Otago reporting system within theatre. He all of the normal checks and balances that we have in place to ensure quality care, he stopped them. He continued to want to do surgery that was outside of the scope of the hospital. And because we were such a small unit, we transferred out any long-term ventilation patients to Brisbane
Mm.
within 24, 48 hours. And he didn't want to practice medicine like that. So he very much interfered with the patients being transferred to Brisbane and stopped them to the patient's detriment.
Mm.
So there were lots of issues that were going on. Some of the doctors and myself tried to stop the esophagectomies from being done because we had researched the procedure. I mean, we all had come from other places. We had all worked and looked after esophagectomies before, but it's a very serious operation that has a lot of complications and should be done in a tertiary centre. So we tried to get them stopped, but they weren't stopped until right at the end when,
Mm.
after Dr. Patel had really been exposed. I think he did 6 esophagectomies whilst he was there, and they all died
Mm.
except for one. And yeah, it was very difficult. And then we had a couple of patients that were really catalysts to us deciding that we were going to go outside of the organisation. At the time, I think I had made complaints to 14 different groups of people
Mm.
about what was going on at Bundaberg's. And I was really, really wanting a vigorous, independent investigation done to look at this, what was going on in surgery and the complications that we were seeing. And eventually I made a major complaint. And I think one of the um, take home things from my experience would be that as nurses, we have to professionally support each other,
Mm.
because I had to go up to the executive by myself because nobody would come with
Mm.
me. None of the other nuns would come with me. And that it was very difficult. After the first complaint I put in about Dr. Patel, they basically made out, they being the executive, made out that it was a personality conflict between
Mm.
myself and him.
Mm.
And they set out to discredit me. They said I had poor communication skills, poor interpersonal skills. I needed to learn to deal with difficult people. There were all sorts of
Mm.
scenarios put out there by people who didn't want to or couldn't look at what was actually going on. And of course, there were other issues involved,
Mm.
political issues, money. For the
Mm.
first time in many years, the hospital was coming in on budget. And he did a lot of surgery. So surgical output was the only way that hospitals raised revenue. So the more cholecystectomies he did, or colostomies or whatever, the more money the hospital got.
Mm.
So the executive was looking really good, so that they wanted to keep that looking good. And so they were happier to try and discredit me as the num rather than acknowledge that Dr. Patel had an issue. So I I tried to deal with it internally. I made
Mm.
complaints to the Director of Nursing, the Director of Medical Services, the District Manager. Dr. Patel didn't report any deaths to the coroner, so the
Mm.
coroner didn't receive any notifications of unexpected deaths or unexplained deaths at the hospital. The notes that he wrote were not accurate or honest, so certain words weren't used in the death certificates and in the notes. Um, I I told you about him running his own morbidity and mortality meetings, not reporting to the coroner. I rang the coroner, and he said basically that so I'm so sorry about my cat. He, there's
Can't.
nothing I can do about
I,
it.
I can't hear it. I
Oh,
can't hear
okay.
it. No,
Okay, good.
it's only
All
your
right.
end.
It's God. Um, anyhow, so the coroner said to me, well, that explains something, that explains what I've been thinking has been going on at the hospital. But I've had no coroner's cases come through, so I can't prove it. Um, I
Mm,
rang the police to see if there was anything that they could do. I was, talked about unexplained deaths, and the police just said, well, don't you have internal
mm,
systems to look at these types of things? And I said, well, we did, but he's stopped them all.
mm,
And that probably is my second take home
mm.
um, advice is, if somebody wants to stop the checks and balances that are in place, there's a reason why they want to do that.
It's
And,
a red a red
yeah,
flag.
it's a
Be aware. Yes.
big red flag, and don't do it. These things must be vigorous, and we must adhere to them. It's like having APRA registration. You don't just stop doing it because you want to.
Mm.
You've got to have robust procedures and that in place to make sure that you are giving quality of care.
I'll just interject there too, because on the back, and I've learnt this from this Sick to Death podcast, on the back of him being recruited, there were red flags elsewhere in the world about this gentleman too. So, there's layers on layers on layers of what actually happened. But
Yeah,
at the center of this was this doctor. But if correct me if I'm wrong, but he actually came from the United States after having similar scenarios there and being removed from service at
yeah,
I believe, two
yeah,
major
yeah,
facilities in the United States. So the checks and balances, you
yeah,
talked about APRA, you talked about the hierarchy at the hospital. Those checks and balances, as far as recruitment and checking, had
yeah.
not taken place.
No,
Mm,
he was recruited via an organisation, a company in Sydney called Wavelength, and on he on his license, at the bottom of the license, it said "See stipulated order," and Wavelength didn't look at what that was. Um, he was recruited. The hospital didn't look at what that was. Medical board after arriving in Australia. They didn't look at what it was. And what it was that he had actually relinquished his license to practice in the States. He was the most sued surgeon at Kaiser Permanente. He was forbidden for doing any surgeries that involved the liver, ilioanal pouches, and I'll talk about that a bit later. Esophagectomies. He basically was only really allowed to be doing things like appendectomies, very simple things like that. He had a history dating back to 1981
mm,
of doing all the things that he was still doing at Bundaberg, falsifying records. He was fined as an intern for falsifying a history and a physical on a patient, and fined, I think, $5,000 at the time. But he had lost his license in New York State and in Portland in Oregon. The states have this. The states have a different system to Australia for licensing. Each state provides its own license. They don't have a standard um, federal license like we do in Australia. So basically, he couldn't work in the States So he came here, and he used to refer to Australia as the third world and say that he was here doing his service, to God, by providing services to the third world and teaching us. He would say that we were very backward and, always denigrating Australia and our medical care. So so this went on, and the attempts to stop what he was doing carried on. Some people got a whiff of something that wasn't quite right from Brisbane with some of the patients that were transferred down there, and some complaints started coming in, but they only came in to one person, and that person didn't share the complaints with anybody else. They came into the Director of Medical Services, and he was aware of complaints from patients, from nursing staff, from other doctors, but he didn't, and from other doctors in Brisbane, but he didn't, he denied that there were any, other complaints. And then there was a man, Mr. Bramage, who died when Patel interfered in his transfer to Brisbane. A caravan had rolled on his chest, and he'd suffered chest injuries, and he had quite a few fractured ribs. And as everybody who's a nurse or a doctor will know, chest injuries like that usually go bad after 48 hours. They compensate quite well. Up until then, he did well. He was transferred out of ICU and decompensated on the ward and came back to ICU in extremis. And we had to try desperately to get him to Brisbane because we didn't have the capability to do anything that he needed at Bundaberg except the basic sort of stuff. We didn't even have enough blood products to, give him a large amount of blood products. Anyhow, he wasn't even Patel's patient, but Patel came in, interfered in the transfer, and Mr. Bramage ended up dying before he could be transferred to Brisbane. That case was a case that really upset the nursing staff. Patel decided that that Mr. Bramage had had a pericardial effusion and did a scan, but he hadn't had a pericardial effusion. But Patel decided that he had, and in his attempt to do a pericardiocentesis, he completely abraded the patient's left ventricle. And the nursing staff that were caring for the patient at the time pretty much were unable to work in ICU after this particular night. That was a case that knocked the staff in ICU for a six, really. And it was one of the catalysts to making the major complaint that I made in the October of 2004 before I went to see Rob Messenger, who was the politician, the local politician, and the media. I put in this major complaint, went to see the district manager and the director of nursing. And then the next month, they awarded Patel Employee of the Month. So we knew that our complaint wasn't being taken seriously at all. And we knew that we had to do something drastic. So by this time, we'd started to conspire with the doctors to admit surgical patients medically in the ICU and then transfer them to Brisbane under the medical banner, where they would be switched over to a surgical service in Brisbane. So people were trying to work around this problem because the people that should have been doing something to stop what was going on or to put limits on what was going on weren't. And so people were working around the problem, which is
Yes.
something that happens a lot
Mm.
when a problem is so big that it seems insurmountable.
And it comes under the banner of innovation. Let's be innovative with our care so that we can
Yeah,
navigate away around the problem.
yeah,
Um, Look, it's it's un it's un I can't imagine the frustration and pain and the anguish that not only you, but also your teammates and the fellow doctors that were trying to do the right thing at that time. I can't imagine, the effect on that team during that period. I remember working in Townsville at the time and hearing it, through the papers, and it just every week there was something new or, something else happened. And you've brought us up to 2004. Toni, you're still living with this all these
yeah,
years later. You
yeah.
still speak it. I've got goosebumps listening to you, just reliving all of those moments. And I guess, the sole purpose of inviting you on today is to give nurses that inspiration and the how important their jobs are in speaking up for the truth and what's right and for patient safety. Um, so, okay, so we've got a nurse who's an example on the ward, maybe 3 or 4 years post grad, and they come across something or starting to see a picture that is a common thread that's compromising a patient safety scenario. And I know that you teach this now, don't you, within the work that you do and the
Yeah.
advocacy and sitting on committees and stuff. What advice would you give to that nurse? And I pick 3 years out, it could be any of us
Yeah,
along, even me,
yeah,
non-clinical, but I see something that's not right.
yeah.
What are the channels of communication? We had so many things put in place from this incident. What are the current things that that nurse should be doing?
Can I just like finish up with what
Yes.
happened? Yeah, so I'll
Yes,
just
sure.
finish up just so the story
Yes.
runs runs okay. But the towards the end of 2004, a young 16-year-old boy lost his leg because Patel tied off an artery after a motorbike accident and didn't go back in and repair his circulation path. And he wouldn't transfer him to Brisbane and his leg went gangrenous. Finally, again a nurse on the surgical ward, intervened and the patient got transferred to Brisbane. And the doctors in Brisbane said that they went down to see the young boy in the emergency department and they said that they could smell him before they knew where he was because they could smell the gangrene
Mm.
from his leg that was still attached. And the young boy ended up losing his leg. And this made the doctors in Brisbane contact the people in Bundaberg and ask, like, what is going on up there? So that the RFDS and the doctors in Brisbane were very aware of that there were issues. But what happened then after I went to the Member of Parliament who tabled my letter in Parliament and patients started coming forward, I went to the media at the same time and I chose Hedley Thomas because of the way that he had reported on Queensland Health previously, and he was a very ethical journalist. And then at that point, they were offering Patel a 5-year contract in Bundaberg. And we knew that he couldn't stay 5 years because he had caused so many deaths as it was. If he stayed 5 more years, it would be complete carnage. So it ended up, all blowing all out of, not out of proportion, in proportion. And Patel went back to the States. And then Headley came up to meet with a group of us here at my house. And as we told him what, all of the story and that. And as he was leaving, one of the nurses said, there must be a trail of destruction somewhere. He can't have become a bad surgeon overnight. And this was in 2005, so it was prior to everybody Googling and using the internet like we do now. And Headley went back to Brisbane and did some investigation and found out Patel's history in the States. And then it was in the paper, and then, all these investigations were done, and the patients started coming out of the woodwork, because at the time each individual patient thought they were the only one that had an issue. They didn't realize it was a wider issue.
Mm.
So getting back to your question, the first thing, going to the media and going to a member of parliament, from my point of view, is the last thing that you do. The first thing that you do is you report on your risk man or whatever internal reporting system you use at your hospital, and you document every single thing, and you keep a diary, and you put in your diary a copy of every single email, memo, meeting, whatever you've had, to try and highlight what's going on or has gone on. You go to your, your line manager, you go to your director of nursing, you go to your district manager, you go to your director of medical services. You try and deal with issues through clinical forums, whatever they may be. One of the things that came from the recommendations from the Royal Commission after Patel was that all unexpected deaths in a hospital must go to the coroner, who will make the decision about whether an inquest is held or not. It's not left up to the doctors in charge. And I just want to add too, back when Patel was the director of surgery, there were no other Australian surgeons working full-time at the hospital. Most of the doctors were here on 457 visas. They were afraid that if they left, if they spoke out, that they would lose their jobs, and Patel would be the only one left standing. So there was a lot of fear associated with speaking out or making a complaint. But they are the things that you have to do. You have to go through the channels. I think with what happened here at Bundaberg, waiting 2 years or 18 months it was. I mean, the first complaint I made was after 6 weeks, but waiting another 12 months before telling the district manager that I was going to take it further. I didn't know where I was going to take it, because I had no idea what to do that would make it a difference, because it could so easily have been swept under the rug. And I was afraid of that happening, like right to the end, that it was all going to be swept under the carpet. And the first Royal Commission was closed down because they said that the commissioner had a bias towards or against Peter Leck, who was the district manager and the director of medical service, and towards me. And they tried to shut the commission down then, but we lobbied the government at the time to continue the commission under a different commissioner, which they did, and he did a great job. But it um, it was really touch and go for a lot of at a lot of different times throughout the whole process. And it's a little bit hard to tell the story because we only became aware of what was going on and the fact that he didn't have a license to practice
Mm.
after it was all over and he'd
Sometime
left
later,
the
yes.
country.
Yes.
We had the story of what we saw,
Mm-hmm.
and we could follow that, the steps of that. But not for 1 minute did I think he didn't have a license to practice,
Mm.
because I thought everybody would have done their due diligence. And, he had references, they were old references dating back years, but they had rung and spoken to some people and they gave him good references. And it's that old story. You give someone a good reference to get rid of them,
Mm.
not all the time, but that is what people do with troublesome employees that they can't get rid of. They will give them a good reference to make them someone else's problem.
Mm.
So I think that's another take home issue,
Mm-hmm.
is that we have to be authentic and truthful in how we practice. We have to be transparent in how we practice, and we have to make sure that we maintain professionalism within our working space so that we don't become so friendly with people that we wouldn't report them if there was a wrongdoing, which was what happened with this case, is that there were friendships and close liaisons that protected and even allowed things to occur that shouldn't, enabled things to occur that shouldn't have occurred.
Mm.
So I think that's another take, what I would, as a take home message, is, yeah, to do those things, stick to your guns. A lot of people still, even after all of these years, I still would get, several phone calls a week from people who
Mm.
are suffering within the Australian healthcare system. And don't get me wrong, I think we have a wonderful healthcare system. But there are people suffering in this healthcare system because of some people not doing the right thing. So when we decide to be a doctor or a nurse or whatever we're going to do in healthcare, we have to make sure that we're going to be a strong patient advocate, to practice ethical practice, um, with truthfulness, um, to be transparent, to follow the process. If 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 you smell a rat, there probably is a rat.
Mm.
So just be on the lookout for that. I think what made it doubly, triply, quadruply harder for me was that people were continually telling me to stop, to stop, to not keep making the complaints, and they wouldn't support me. They it was daily gossip in the corridor that
Mm.
this was going on, and people were saying if they came into hospital, don't let Dr. Patel
Mm.
touch me. And this was common conversation. It was discussed amongst the staff about who could go to a member of parliament. And, some of the other nuns said things like, well, I can't do it. I'm the breadwinner of the family.
Mm.
Everybody was,
Self-preservation.
yeah,
Yes.
you do it, Toni, because you're single and you don't have
Mm.
anybody to support,
I was
you
just I was
know.
just going to say, like, there's been a number of times in my career where I've had to go forward to a committee or present something that needs answers to, and I've done it in isolation because of the other people just don't support, or they actually you ask for support and then they don't turn up. Um, and it's purely self-preservation reasons. They don't want to get hooked up into untangling a big web that they know is there.
Yeah.
So, I mean, for nurses that are feeling isolated, where do they get that support from if they're not getting it from their local managers or their mentors? Are there avenues there for support?
There are different organisations like around Australia. How effective they are, I don't know. I mean, the
Mm,
obvious ones are the nurses' union,
mm,
and the nurses' union were at the time, because of the personalities of the people in the nurses' union at the particular time, they were very good. To us. They were excellent. They came up. They spoke with the director of nursing. They came back down to the ICU and they just said, look, she's just going to discredit you. That's what's going to happen, that she's not going out on a limb to, to look at what's going on with him. She's just going to discredit you. And at that time, I had looked back through the patients that had died in the ICU, and there were 14 patients that had um, unexplained deaths or suspicious deaths, none of which had been reported to the coroner. And I told her this, and she just said to me, the union person, she just said to me, well, you can't collect that data and not do anything about
that's
it.
right. And it ended up like from your one patient 6 weeks in to 14 patients at that point. And I think I heard on the podcast that 97, is that
Yeah.
right?
Yeah,
Nine,
87. They identified
87.
87 deaths. He
Mm,
he operated on around 1,400 patients
mm,
in the time he was at Bundaberg. And when he left, and they all had to get reviewed because he didn't do things like staging CTs or biopsies or anything. He just went in and whipped off a breast and did a Whipples. And, there were several patients that had had Whipples done that didn't even
didn't
have
need them.
cancer, and they died from the surgery.
Mm,
So the surgeon who was doing the investigatory surgery after Patel had left, well, they had to do 1,200 forms of corrective procedures, or not just surgery, but things like extra colonoscopies or gastroscopies or
mm,
things like things like that. So the statistics were enormous. And I think that the lessons that should have been learnt should have been so um, strong that it should have made our healthcare system, very, very robust. But of course, we know that there has been issues, not to the same degree, but there has been issues
mm,
since then,
mhm,
which is sad.
mm.
Mm. But
It's
there
it
are, getting back to your question, there
yeah.
are different places and people that you can go to, but it all depends too, like the how effective the union is and how willing the union is to support whatever the issue is that the nurses are going to them with. Um, a lot comes down to personalities, unfortunately, but yeah, I think we've got a long way to go, and I think we as nurses, we have to be very aware that we have to support each other
Mm.
within our profession, because nobody else will.
No, and the power's in the data, isn't it? The power is in the numbers. It's in the
Yeah,
data collection that you get. As nurses, I think everybody gets a little bit emotional when these things happen to our patients, and you want the best for your patients to come forward, but at these times, this is when emotions do run high.
Yeah.
But your baseline is the data. It's the facts, it's the
Yeah.
figures, and to stay fast. And really wise words there about documenting, because you never know where your suspicion is actually going to go into the future with other patients or other scenarios, and you never know where that's going to end up. And
Yeah.
and I have heard, and that some nurses actually squirrel away their documentation for fear of it being covered up. And that is a reality. So if you do need to, take
Yeah.
copies
Yeah.
of what you've done, take it
Yeah.
away with you, because
That
um,
I did that
yes,
because I was so afraid that the notes were going to disappear.
mm,
And so I photocopied Mr. Bramage's notes and um, some other notes and took them home. And the effect that that had, I think, made the commission and the government made sure that they were truthful in what they did because they didn't know what someone else had at home to come up with if they didn't tell the truth.
isn't that frightening that you've got to get to that
It
stage?
is frightening and
Yes.
it's a terrible burden to put on someone and it's a terrible position to put somebody in.
Mm. And of course,
And
it's against everything that we've been
it
taught.
that's
Absolutely.
exactly right.
Yeah.
Yeah, that's exactly right.
Mm.
So but one of the main issues when it came down to the manslaughter trial for him, because he was charged with 3 counts of manslaughter, one of GBH and one of something else, I think, initially, was that the doctor's notes weren't truthful. And the prosecution got most of the evidence for the cases that they decided to proceed with from the ICU nurses' notes because they
Mm.
were truthful.
Mm.
So yay for nurses
Absolutely.
and don't underestimate the power of a good note, a
Yes.
good documentation,
Mm.
because it was, initially he was convicted on all 3 counts of manslaughter, but he was granted a new trial after 2 years. And they decided that they weren't wasting any more money on him and sent him back to the States.
Mm. Mm.
Yeah, so with your documentation, that was because I felt very guilty that I at the end, and especially when we found out his history, I felt very guilty that I hadn't done enough in that 18 months. And when I went back and went through my emails, and thank God I don't ever throw anything out, and I don't throw anything out, um, I looked at what I had done and I thought, no, I had done all that I could.
Mm.
And people think, oh, whistleblowers, and I don't like the term particularly,
Mm.
they think, oh, whistleblowers are disloyal to the organisation.
No,
But in actual fact, they're
it's the
not.
opposite.
It's the opposite.
Yeah.
They're loyal. And I tried to be loyal and I tried to work within the system and
Mm.
go to every single person within the hospital, but it didn't work.
No,
And when it didn't work and more people were dying, it was time to do something drastic. And
absolutely.
we didn't, as nurses, like we discussed, what possibly else could we do? And we made a joke, do we get naked and hang from the tree outside Red Rooster? Like, what is going to make
Mm.
people stop and look at what's going on here?
Mm.
It was an incredibly frightening and destructive and a horrible time to go through.
Mm.
And it was, yeah,
And the job's not over yet, is
no.
it? You're
Well,
still working, huh?
it's not
No.
over until we have things cemented in place
Yes.
that are watertight in
Yes.
terms of policies and procedures and protocols and you know um
And that we have work environments where people can actually bring up this. And I
yeah
think, you know, the evolution since this has happened, it's definitely a whole lot better because of these scenarios, but there's still more work to be done.
yeah
You're currently working in this space too, aren't you, on committees and things? What are you
I
doing
I
now?
I yeah I do work on some different committees, not within any hospital system.
Mm,
At the moment, I teach casually through JCU and CQU,
hmm
and I'm hoping to start my PhD this year, and I'm doing it on barriers to reporting
mm,
because I want to look at the different barriers to reporting, what people perceive as the barriers to them speaking up.
mm,
People still aren't comfortable speaking up. They still, and I think that they're right. We still don't have transparent, independent, um, ethical departments anywhere. We had a visit from the ethical standards branch during at this time, but it wasn't to support us, it was to threaten us.
mm,
Don't do this because you'll go to jail.
mm,
We were threatened with jail several times, and and it wasn't an idle threat.
mm,
It was a definite, visit by the district manager to the ICUT room to tell you that whoever leaked this letter will, will
mm.
go to jail.
See, in those committees, you actually look to them for guidance and support. This is what you need to do. Step one,
Yeah,
step two, step three. Highlight what avenues that you can take this. So
yeah,
yeah. Provide that leadership and guidance for staff.
yeah,
Yep.
yeah,
Mm. Missing.
yeah, 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 yeah.
Mm.
But yeah, so there, I mean, the messages that I've given you, the take home messages, they're the main the main ones that I think when I look back at what happened, what would have helped
Mm.
um in the situation that we had.
Mm.
And remembering we didn't know what the actual situation was
Mm.
until well after the time.
Until it all unraveled.
Yeah,
Yes, yeah, definitely.
yeah.
So with your PhD, is this a definite thing that you're doing?
Well, I hope so.
Yeah.
I'm hoping to do it through Griffith University with Professor AJ Brown, who did a big project on whistleblowing called
hmm
Whistling While They Work, and he's
Mm-hmm.
the head of Transparency International in Australia
Mm-hmm.
and Professor of Public Law at Griffith Uni. And I've
Mm.
done a lot of work with him
Mm.
over the years since this happened.
Well, you're more than welcome to use my community because it's growing. And so I'm
Yeah,
doing these podcasts, with a PhD obviously is over an extended period of time. But if you're looking for people to contribute towards your
yeah,
thoughts, you're more than welcome to post in that Facebook group.
yeah,
Just let me know. But if
yeah.
anybody else is listening to this podcast and they have maybe some questions, what's the best avenue that they can communicate that with you? Do you have an email did you,
Yes, I have an
or
email.
yeah?
Yeah, yep. Do you want me to give you my email or do you want
Let me know
both?
what it is and I'll put it on the podcast with your
Okay,
permission.
sure.
Yeah, I'll put
Yeah,
it on the description underneath
yeah,
so that people can reach back to you. That will be
yeah,
wonderful.
yeah,
Yeah, yeah,
yeah,
awesome.
yeah.
What's your golden nugget out of all of this? You've given us some really good tips on the way through with our conversation today, but what's your number one key thing if you could pull it out from your experience?
It would be to be the best patient advocate that you can be.
Mm,
It would be, yes, you might be a pain in the posterior. Yes, you may make yourself unpopular at times or whatever, but just be the best patient advocate you can, because those patients are looking to you to protect their safety and to protect them, and to speak up for them when they can't.
Mm.
And Patel was so convincing when he spoke to the patients that they all thought he was a god. You know, here he was in this little town talking with an American accent, telling them how he'd been the head of trauma surgery in New York for so many years, and he'd been at the head of cardiothoracic surgery and the head of pediatric traumatology. And, you know, like he had more, you know, degrees than a thermometer. Um, but he didn't. He was a liar, and he was a con man, and he was a clever con man. And it's a shame that he didn't use his smarts to do good for the world instead of
Yes.
do such bad,
Mm.
because it's a waste of intelligence. But anyhow, that's sort of like beside the point. But
Mm.
um, yeah, but as nurses, support each other, stand up for each other, have each other's back, you know.
Mm.
Yeah, so that we can make our little, you know, profession a tight, ethical profession that has patient care at its heart. I
Mm.
mean, doctors are much better at it than what nurses are. You know, doctors are much better at sticking up for each other than what nurses are.
Mm.
So it's
Yep.
something that we have to do.
Yes. Bring it forward with one voice, a collective.
Yeah,
Yeah, definitely. Tony, thank you so much for your time today.
yeah.
And
You're welcome.
I just want to say, and I'm actually going to preempt this recording with a bit of an announcement. I'll add that in at the end. But if any of this has been triggering for you, we do encourage you that you do seek mental support or some professional support if you're upset by any of the issues that we've discussed today, because I know that that could be the case with a lot of our listeners today. So, but I thank you, Tony, for being very honest about what happened and expressing, the thoughts and feelings and frustrations that you had going through that. I really appreciate that honesty. Mm.
Okay, thanks, Wendy.
You're welcome. So you've been listening to Your Nurse Voice Matters. I've had the beautiful Toni Hoffman with me today, and I look forward to presenting to you our next episode. Bye for now.